invite Dr. George Ruby from Royal North Shore. He's a radiation oncologist.
So good morning. Thank you for the invite, Michael. And Roz, thanks for setting such a nice background for me. Makes my job easier. So I'm going to give you an unabashedly biased rad-onc perspective here. So what is secret rad-onc business? First of all, let's talk about, post-prostatectomy radiation treatment. In the early 2000s, we got together really to set the stage for the RAVES trial, quite an important trial of adjuvant treatment versus early salvage. Now, clearly, in this setting, we're not treating a target. There's no prostate. We're treating a potential space. And what does our field look like? Put your eyes on the top left screen. It's a toilet seat. Look at the yellow. It's a toilet suite. The bowl of the toilet covers the anastomosis where the prostate used to be, and then that sort of tall cistern covers the seminal vesicle beds and the rectoprostatic sort of gutters. Clearly, we don't draw toilet seats in a sagittal section up front. This is a composite of actual slices that we do in 2mm cuts. And I'll show you how PSMA PET has really improved our art. So this has been the bread and butter since 2005. Now, until you guys came along and, as Roz said, changed the game, we were shooting blind. We were just basically putting on these fossa fields and not really knowing what we were targeting. So if we salvaged 100 men, we only really cured about 50. If you were lucky enough to have a Gleason 7 margin positive tumour, you might have a cure rate of 60-70%. The rest of the men, we salvage 20-30% at best. And as Roz has already indicated, Roz hasn't indicated, what is important to us as radiation oncologists is low PSA at time of treatment also makes a huge change to cure. And if we're salvaging at 1 or 2, it's probably too late. So it didn't take a rocket scientist to sort of figure out that PSMA can come in here and really help us. If you're chasing the fossa and you've already got a pelvic node, you're not going to cure that patient. And certainly in an early experience from North Shore and St Vincent's, we saw that 20-30% of these men will have disease in the fossa, another 10-20 in the pelvic lymphatics, and another 5-10 further afield. So now we can deploy newer technology, and the sweet spot for rad-onc referral is somewhere between 0.2 and 0.5. Roz has already nicely demonstrated this correlation between PSMA and PSMA PET, and clearly once they're above 1, they're often already metastatic. But PSMA PET matters too, and we should still be seeing, as radiation oncologists, patients with a negative PET because they're very highly curable. And just cast your eyes on the far left of the bar graphs. If you've got locally recurrent disease in the fossa or a negative PET, you've got probably an 80% chance of being salvaged with simple radiation treatment alone. Now, we can get more techie these days, and these are some slides from the SPORT trial, very big US study looking at salvage fossa alone, salvage fossa plus 4 to 6 months of ADT, and really the kitchen sink approach of, there's the toilet seat again, pelvic lymph node basement field, plus 4 to 6 months of ADT. So you've got this sort of gradation or escalation of modern techniques. And so clearly, that has helped. Now, I'm just going to take a detour for a sec, because I just want to talk about the way you are impacting and improving what we do. You guys are improving our craft. And what we did was every week we sit down with our nuke med colleagues, we look at where recurrences happen in the fossa, and more we were thinking, these all happen up and down the back row. They all happen around the anastomosis. We're over-treating that top left corner of the toilet bowl. And sure enough, we sat down, we mapped everything out in 3D. These are all recurrences from both St Vincent's and Royal North Shore and Sydney. And what we found was 2 real things. As I said, recurrences all happening down to the anastomosis and up and down those rectoprostatic gutters, SV remnants. And so the Dutch have taken this one step further. They've already published guidelines. Just look at the top left. On our original FROG guidelines from 2005, the toilet seat was about 3 centimetres sup-inf. They're down to 2. So they're going to spare quite a lot of bladder. So hopefully your work is helping our work help patients and reduce GU toxicity. I think this is important. Our FROG, which is the local faculty guidelines, are being updated at the moment as well to reflect some of these changes we've picked up. So different patterns might reflect better surgical techniques as well, to be fair. So we've got this gamut of possibilities, from observation to treating the fossa, to treating the fossa and the nodes, to deploying ablative technologies. So some of those nodes, Ros, we can now absolutely annihilate with really focused SBRT or SABR. And all of this can be mixed and matched with various levels of systemic management. Now, this is a very early paper of PSMA detected and PSMA PET guided SBRT. And at first it looks woeful, but I think in retrospect we set ourselves too high a bar. And Andrew Kneebone was getting really depressed. Look, everyone sort of fails by 18 months. But if you account for subsequent salvage, and also the fact that a lot of these guys had just had definitive radiotherapy, so the Nadir plus 0.2 definition was probably far too staunch. We've got one of my registrars to update this data, and now we've got 120 sites and 103 men and much longer follow-up. And guess what? That 15% tail is more like 30% if you account for subsequent salvage treatments. 50% of these men have not yet been exposed to ADT. So it's exciting, but I'd really still like to know, is Mr. Smith going to get away with just repeat SBRT applications for 5 years? Or is Mr. Jones going to progress systemically no matter what we do? And we need to be better at personalising these therapies and not just coming up with class solutions. Again, that's just a rephrasing of what I think I've already told you. Now, there are lots of trials coming up, and I just want to quickly call out two. Popstar 2 is quite funky. I think it's one we're about to start in conjunction with the Peter Mac. That's we're sandwiching, SBRT with 2 cycles of lutetium, so that'll be interesting to see if lutetium can damp down the microscopic disease that Ros has already alluded to. And because Ken's in the audience, Primordium is a nice, I love the name, but it's a really nice way of looking at whether, if you're pelvic lymph node positive, does upping the systemic treatment, being more aggressive with the systemic treatment, lead to better outcomes in the context of wide pelvic nodal radiotherapy. Just as an example of personalising therapy, this is data from Dan Spratt, and basically we can look at genomic classifiers to see who will recur, and these are 15-year prostate cancer mortality endpoints, so very, very hard endpoints, and you've got a much higher chance of eventually failing if you're a high decipher category, and perhaps these are patients that should be getting androgen ablation. So for men with post-prostatectomy rising PSA, please refer to us early. I've hoped that I've shown you that PSA helps both prognosticate and predict. Decipher may be useful, and to actually quantify the benefit of PSMA PET, I think we're waiting for the Empire 2 study, which Jeremy Calais is running. I personally think we need more flow cytometry stuff. I think we need AI. I think we need radiomics to personalise these treatment decisions we make and get away from class solutions, trying to fit Mr. Jones into a box. I've got 1 minute left. What about BCR post-definitive radiation treatment? So Ros has already kindly defined this for us. 2 caveats. Be careful, older patients, more comorbidities. So perhaps consider the PSA doubling time and the disease-free interval before you rush in and salvage someone after a radiation treatment failure. The other thing is it oligometastatic? Is it polymetastatic? Is it a true isolated local recurrence? Now, funnily enough, isolated local recurrence with modern, decent radiation treatment is not that common. Less than 5% of our cohort had any element of local failure when we tracked them with PSMA PET. If local recurrence does happen after radiation treatment, you can salvage these patients with a salvage prostatectomy, but that can be morbid. We're running a focal SBRT retreat program at North Shore that we set up in 2017. Other options are cryo, HIFU, and I think Nathan Lawrenchuk here in Melbourne is promoting the nano knife. These are our 2-year results in our first 37 prospective patients that we've retreated. The patients had to have concordant PSMA, MR and biopsies, and the results are looking good. I can tell you that at 5 years we're out at about 50% freedom from failure, and we've only had 1 grade 3 or more toxicity, so really exciting. And that's how we compare with the sort of systematic review of the literature. Thank you for your time.